ABI screening, you said, how do we do this? Is there any controversy there? I don't think there's any controversy that if you measure the blood pressure that you're fine. There is some controversy about the oscillometric method, whether that is accurate or not. You have some people on one hand say, yes, it is. Josh published a nice paper showing very good correlation. On my own hands, I found pretty good correlation between ABI. There is some slight differences. I think the oscillometric method, the level is a little bit higher sometimes than the pressure method. And at extremes, you might see some differences. But generally, just for screening, it's pretty good. Next slide. So next slide. Keep going. Keep going. One of the issues is that, why screening is important in PAD is there's a certain amount of people who are really asymptomatic and don't have that. So it's not like you can go in the office, get a history of medication, fill for pulses, and then absolutely make the diagnosis of PAD. Unfortunately, as clinicians, we're not just that good. And that's why the guidelines which you'll see next advocate ABI testing. Next slide. So these are potential groups that are at risk: age less than 50, age 50 to 69 with a history of smoking or diabetes, age 70 or older, leg symptoms with exertion, abnormal lower extremity pulse exam, or known atherosclerotic disease in other territories. Next slide. So you said are there guidelines out there for measuring for PAD? This is the ACC-AHA guidelines. They say here, exertional leg symptoms, age 50 to 69, everyone greater than 70, or leg or foot ulcers should be screened with an ABI. Next slide. Test 2, documents, which are international documents looking at PAD. Recommendations are recommendation 12, measure ABI and exertional leg symptoms, age 50 to 69, everyone greater than 70, or if you have a Framingham risk score in 10 to 20% range. So the American Diabetes Association also has recommendations for measuring ABI, asymptomatic diabetics greater than 50, universal screening for ABI, asymptomatic diabetics less than 50, who have the following risk factors: smoking, hypertension, hyperlipidemia, and diabetic patients of any age with symptoms for diagnostic ABI.
Okay. So specific question. So you're saying there's a consensus on PAD screening. Reproducibility, is there any issue in terms of like ABI 0.9 versus 89 for 0.95?
My opinion is, and I can't quote you any data about it, just off the top of my head, reproducibility, but I don't think it's an issue. It's like, is there reproducibility measuring the blood pressure? There's some, obviously, there's some variation.
Well, with blood pressure, we know there is a huge reproducibility issue, and that's why ambulatory blood pressure is, preferred mode. But with PAD, you're, triggering next step. So, what is the extent of reproducibility issue? 10%? Matt and
I would actually, I think you can short circuit the conversation by saying that there's no difference as long as you're under 0.9. It doesn't matter. There's no difference if you're at 0.8, 0.7, 0.6, or 0.5. You're going to get full medical treatment. So whether or not you change 10% or 20%, as long as you get below the threshold, you're done.
The threshold is 0.9.
Yeah.
Well, the threshold is 0.9, except that people between 0.9 and 1 still have an increased cardiovascular risk. So really a normal value is 1 to 1.2.
Right.
So I would just like to propose that, because we're not talking about repeat studies, that instead of talking about reproducibility, which is the wrong term, we talk about measurement precision.
Yeah.
And measurement precision is not a problem with coronary calcium, because a score of 100 is going to be between 90 and 110. You're going to classify them roughly in the same place. ABI, probably, we have no idea, but 0.85 to 0.9 or whatever. If you're off by a tiny bit, it's not going to totally reclassify the patient.
It's got pretty good precision.
Pretty good precision. I think IMT, arguably, without Alan Taylor's newest data, may have a measurement precision problem, not a reproducibility problem that we need to
We're going to get to the
I'm just saying, but that's the term.
Okay.
How is that we should be thinking about?
How is it that you got such societal sign-off on PAD screening in the absence of outcome studies?
Well, let's put it this way. People have been treated specifically on the basis of PAD and had event reduction. So you were entered into the heart protection study with PAD, and in the PAD group without coronary heart disease, the risk reduction in heart attack was the same. You were entered into the HOPE trial with PAD but without any coronary heart disease, your event reduction was the same. So there's already outcome trials on the basis of the disease itself.
But not comparing patients with and without PAD screening. in terms of
Right.
outcomes.
There's no randomized
That's right.
trial.
Right.
So the issue, but part of the difference in what we're talking about, I think, is, I guess what I would say is, you're making the diagnosis of a disease versus trying to use the extent of atherosclerosis as a predictor for outcome. I think with coronary calcium, it's closer. With IMT, it's going to be harder to establish that link because all the event rates are so low in all the big trials. But I think the difference is people were entered into a trial on the basis of a low ABI, and then their cardiovascular outcomes were studied. The first part, is it worthwhile to screen 1,000, to find 100, and then enter them in has not been done.
Before Michael leaves, so the conclusion on the PAD panel is there is consensus, reproducibility is reasonable within this range, and the arm force for doing the test should not be definitely RBT only.
Right.
That's right.
I would say, by the
Precision
way,
is reasonable.
I would say, by the way, that, Harvey, there isn't widespread agreement. There are medical societies that strongly oppose screening for PAD.
Michael, can I just one super
Yeah.
quick question? Is there a society that deals with PAD? I mean, U.S. Preventive Task Force has said no, ADA said yes, but is there a body of people who do PAD, and are they organized in any place?
So the Society for Vascular Medicine is probably the best society to address this, and Josh is the incoming president.
Great, and that's what we're going to the last, when Valentin is leading this, what about coalition. Michael, thank you for coming.